Nishava Thompson, and I am currently a Bachelor of Psychology student at the University of Guyana. And I would just like to say that suicide has always been an issue here in Guyana. Our suicide rate was the highest in the world for over 3 years. And to date, the battle to reduce our suicide rate still rages on. But for us to win this battle, we must spread awareness. Today, we are here to listen and learn about suicide contagion and clusters. Our distinguished speaker is an associate professor of epidemiology at Columbia University, Mailman School of Public Health. Her research focuses on psychiatric and substance use epidemiology across the life course, including early origins of child and adult health and cross-generational cohort effects on substance use, mental health, and injury outcomes, including suicide and overdose. She was the recipient of the Carol J. Rowland Hugh Mid-Career Award in recognition of this research. She also sits on the editorial board of the Injury, Epidemiology, and Drug and Alcohol Dependence journals. Her areas of expertise include, but are not limited to, data science, research design and methods, adolescent health, autism, post-traumatic stress disorder, stress, discrimination and bias, depression, and mental health. She is the author of more than 300 peer-reviewed publications and 2 textbooks published by Oxford University Press, Epidemiology Matters, A New Introduction to Methodological Foundation, published in 2014, and Population Health Science, published in 2016. Ladies and gentlemen, it is with absolute privilege and honor for me to present to you the beauty with the brains, Dr. Katherine M.
Wow, thank you for that introduction. I really appreciate it, and I really appreciate the invitation to speak with everyone today. I'm looking forward to hearing thoughts on this work. Can everyone see my slides? Great. So I'll be talking today about some of the work that my colleagues and I have done on spatial and temporal correlations in suicide in the United States. I think that I'll talk a little research more generally too, and I think that a lot of the work that we've developed for how we do research on suicide in other countries as well. So I'm looking forward to those thoughts too. And as the introducer mentioned, suicide continues to be a major public health problem. About 800,000 people at a minimum, based on recorded suicide claims about 800,000 lives every year. It's the second leading cause of death among youth. It accounts for 57% of all violent deaths and 1.5% of all mortality globally. And that's more than malaria and breast cancer and many other diseases that we also consider to be major public health problems. Suicide is a tragedy that has a tremendous impact on survivors. Its impact on families and communities is far-reaching. Suicide has touched my own life. My son's father died by suicide 3 years ago, and we continue to, really deal with the fallout of that personal loss to me and to my son. There's grief, there's stigma that's involved in a suicide death in a family, and subsequent increases in psychiatric conditions and suicide rates really reverberate across generations. And so what we try to do from a public health standpoint is really try to do prediction, trying to predict who will die by suicide or who will engage in intentional self-injurious behavior, and then prevention to prevent these suicides from taking place. But suicide is not just an individual level phenomenon as an outcome of psychiatric conditions. It's really a societal outcome of certain environmental conditions. And this has been shown for many centuries in terms of the spatial and temporal correlations of suicide. For example, in his 1774 novel, The Sorrows of Young Werther, my apologies. Goethe tells the story of a sensitive young man who takes his own life because of an unrequited love. Soon after its publication, men in Germany began dying by suicide using similar means as the character and even dressing in similar clothes as those described in the story. The book, as well as Werther-style clothing, were banned in Leipzig in 1775 and in Denmark and Italy shortly thereafter. 2 centuries later, the term a Werther effect became commonly used to describe increases in suicide after well-publicized suicide events, the effects of which have been demonstrated globally. For example, this is a 2012 meta-analysis of 10 studies tracking changes in suicide rates following media reports of celebrity suicide, indicating overwhelmingly positive effects and suggesting that the suicide rate on average increases 0.26 per 100,000 in the wake of these high-profile events. And indeed, celebrity suicides is just one example of the potential contagious effect of suicidal behavior. As the story of Werther demonstrates, fictional depictions of suicide that are widely disseminated, family and friends dying by suicide, a close community member of dying by suicide, all increase the risk that suicidal behavior and completed suicide will occur, especially among young people. In our own work, and more recently in the United States, the death of the notable entertainer Robin Williams was met with widespread coverage that graphically detailed the means and methods of the event. And work by our group demonstrated that in the months after his death, there were increases in suicide in the US, well beyond that which we'd expect given yearly trends. We estimated that overall there was an excess of about at least 1,841 cases of suicide in the 4 months after the death of Robin Williams, above that which would be expected. So we've started to put this together in a framework for how we can think about suicide as a contagious process and as using some of the same epidemiological methods and tools that we've used to characterize infectious diseases for centuries. So if we think about the classic epidemiological triad of agent, host, and environment, there are many agents that are involved in suicidal processes like media reporting, close contact, owning a firearm. There are host factors, personal history of psychiatric disorders, family history, previous suicide attempts, and other stressful life events. And then there are environmental conditions. Suicide varies with respect to the season of the year, the temperature, altitude, and country and other local dynamics. But what we've seen in the United States really is that across the board, there have been increasing suicide rates since about 2000. And this really goes across all different age groups in the United States. It's not we're not at the highest suicide rate that we've had in the United States. That goes back to, the earlier part of the last century. But really since 2010, we've seen a steadily increasing suicide rate in the United States. And that's what my research group has really been focused on in the past few years, is trying to understand the spatial and temporal correlations of that increase in suicide in the US. So I want to present to you is a couple of studies that we've recently published that have tried to unpack and untangle the sources of variation that are driving this increase in the United States in the past decade. This year, we published a study in molecular psychiatry where we decomposed the suicide rate in the United States across 3 different groupings: age, period, and cohort. Cohort effects measure an array of environmental exposures that vary, that apply to individuals born within the same historical context and may differ from those in people in other contexts. For example, American baby boomer males, these are males born between 1946 and 1964, have consistently found to have higher suicide rates than in other generations. And they're carrying that higher suicide rate with them as they move through the life course currently. Age effects, on the other hand, result from biological and social exposures that are really specific to development. And period effects refer to external factors that impact the whole population at a given point in time. So the suicide rate currently is increasing among everyone in the population, and then it's increasing more and less among certain age groups. So that overall increase that's affecting everyone is driven by period effects. And because of this, age period cohort effects and age period cohort models have been used to investigate biological, social, cultural, and political causes of variations in suicide rates. And so that's what we were specifically focused on in this study. So for this study, we used information from death certificates that were with state vital registration offices, and they include basic demographic information such as the age of death, the sex, the race when available, as well as the means and manner of the death as recorded by a physician, a medical examiner, or a coroner. So we assessed, so for example, whether a firearm was involved, which is about 50% of deaths in the US. So we first assessed the suicide rates over time using categorical age as a predictor, and then we included nonlinear variations over time that we could attribute in certain ways to period and cohort effects. And this is known as a Cartesian method, where we estimate linear effects of period and cohort, known as a drift parameter, and then estimate deviations from that parameter that are attributable to specific periods and cohorts. But the first thing we did was really visualize the age, period, and cohort effects using these hexagonal maps. And these are becoming commonly used in age, period, cohort research, because you can really visualize the age, period, and cohort effects simultaneously. So to orient you to these hexagonal maps or hex maps, each of these hexagons is the color of the hexagon represents the suicide rate for that specific age group in a specific period at a specific point in the life course or birth cohort. So you can see each of these cohorts are arranged on a diagonal. And so you can kind of see the experience of each cohort as they move through the life course. And then each vertical line is period. So we're moving forward in historical time throughout the study period. And then each of these vertical lines represents an age effect. And we separated this by males on the left, females on the right, and then firearm deaths and non-firearm deaths. So in the male firearm suicide, there's a really clear age effect. The lowest rates are at very young ages, and then the highest rates are among very old ages. So for men, firearm suicide rates really start exponentially increasing at older ages. A period effect is also evident, because you can see the suicide rate is really increasing across all ages. But you can see this cohort effect here, this cluster of increasingly red dots. That is men, baby boomer males, men in middle age, about 40 to 70 years old. For non-firearm suicides, the rate is generally lower than for firearm suicide, but the trend is similar, except for that excess death among older men. For older men, firearm suicides are really the predominant cause of suicide death. And age, period, and cohort effects are also evident among women, but women have a much lower rate of completed suicide compared to males. So it's not as visually clear what's going on, but you can still see this kind of increasing rate over time, and especially for people in middle ages. And this is especially true for women for non-firearm suicide. So when we break this down by age, period, and cohort effects, we can really visualize those hex maps in a quantitative way. So panel A here is the age, period, and cohort effects in firearm suicide. These are the age effects, and this is also stratified by race. So you can see, for example, that the highest suicide rates are among white men, and you can see that really clear age effect with the increasing rate at older ages. And then the right-hand side is the period and cohort effects. So this line right here is the cohort effect in suicide. And so you can see in particular for Black or African-American men, there's a strong cohort effect for men who are born in the late 70s and early 80s. And less visible over here are the period effects. And here it's somewhat hard to see, but there is a really quickly increasing slope in the period effect for suicide. And that's indicative of the fact that suicide rates are increasing really across all ages. So that's summarized here, but they're particularly increasing for Black or African-American men in this particular birth cohort, and then for older adults in these particular racial ethnic groups. You can see somewhat differing trends for non-firearm suicides. You don't see that big age effect like we saw for firearm suicides, but you can see that there are particular cohorts where there's a really rapidly increasing rate of non-firearm suicide, particularly among Asian and Pacific Islander men. And similar, there's a strong period effect. So suicide rates are just increasing across the board overall. For women again have a lower suicide rate compared to men, but still some age, period, and cohort effects do emerge. For firearm suicides, we're seeing particularly pronounced increases among young cohorts of Asian or Pacific Islander women in particular, as well as Black and African-American women. And really these are girls. The youngest cohorts are those who are adolescents and young adults. So it's particularly concentrated among young minoritized youth who are rapidly increasing suicide compared to rates of their racial ethnic group in previous generations. But again, the strong period effect is indicative of the fact that suicide still is remaining increasing overall across all populations. And you see similar effects for non-firearm suicide as well. For students, we also make all of our code available. So anyone who wants to play around with doing age period cohort models or replicating any of our results or using some of our hexagonal map approaches for your own age period cohort investigations, you can go to this GitHub link. And if anyone wants to email me, I can send it to you as well. We have code available for all of the papers that I'm going to show you today. So basically what we find is that suicide rates are continuing to increase in the United States, and these age period cohort models suggest that young cohorts of particularly minoritized adolescents are an emerging risk group. But that being said, we have suicide mortality increasing in the US from 1999 to 2018, regardless of method, sex, race, age, and birth cohort. It's just increasing really among everyone. And then it's these particular groups where we see the biggest increases. So we think the results enhance our understanding of the role of sex and race in suicide method and the national increase in suicide. Two findings to really highlight because they have possible public health and clinical implications. The high rate of firearm suicide among older men should really encourage the development of suicide prevention programs aimed at this population group. And there are a number of efforts to do that, particularly, kind of teaching people who are caring for their older parents, for example, to start to be more aware of the signs of potential suicidal behavior in their aging fathers and grandfathers. And there are numerous population programs that are underway in terms of firearm safety for suicide, in terms of locking firearms when someone is in a suicidal crisis. Second, the increase in suicide risk in younger cohorts of non-white racial groups, especially Black girls, really, we want to highlight that. For the need to act on social, economic, and political drivers of minoritized populations' adverse experiences, and reducing racial ethnic differences in access to and the quality of mental health services through evidence-based approaches, including things like culturally adaptive programs. So the next study that I'm going to present to you is another paper that we published this year in the American Journal of Preventive Medicine. And here we really wanted to focus on understanding the role of firearms in the increase in suicide in the United States. We know that 50% of suicides are by firearm, and that it's a particularly lethal way to attempt suicide. Approximately, it's nearly always fatal, but it's also an impulsive act. 90% of people who survive a firearm suicide attempt do not reattempt suicide. So it's a really important aspect of suicide prevention. This is embedded in an American gun culture where obviously there's a lot of discussion around the right to ownership of guns and the safety to self and others from firearm ownership. So we really wanted to determine what the contribution of firearms are to the increase in suicide. If firearms are causing an increase in suicide, then we should expect to see things like firearm ownership going up or the relationship between firearm and suicides to be changing over time. So we were able to obtain state level data on household firearm ownership. RAND develops a score for each state that is from compiled data from a number of different sources, including the Behavioral Risk Factor Surveillance Survey, Gallup, the General Social Survey, and the Pew Research Center, all of which does their own surveys in terms of doing surveys of firearm ownership. And so they compiled all of that information together, as well as with 5 indirect measures, including the proportion of male and female suicides that are by firearm, the hunting license rate by state, guns and ammo per capita subscribers, which we know correlate with firearm ownership, the rate of background checks, how many people are applying for a background check to own a firearm. And from that, RAND develops a factor score. So each state is given a factor score that we use to estimate prevalence of firearm ownership using all of these different indicators. We recalculated the RAND firearm ownership rate, excluding the information on suicide, because obviously that's our outcome. And so we didn't want to include our outcome in our assessment of the exposure. But it really didn't have a demonstrable impact on the factor analysis. But what I'm going to show you today does not include any information on firearm suicide in estimating the firearm ownership rate. So, and we had this information available from 2001 to 2016. That's how far the RAND data goes up. We have suicide data through 2018, but we only had firearm ownership through 2016. But so we did some descriptive analyses of the spatial temporal variation. We developed what are called hierarchical age period cohort models, where we're estimating the age period and cohort effects in a flexible random effects model that allow us to include covariates to assess mediation. So essentially we were asking how much of the increase in the firearm suicide rate is attributable to changes in firearm ownership. And we also included a lot of state level covariates in those models, like the percent of adults who are unemployed, the percent of families living in poverty, median household income, population density, and mean elevation in feet. And we know, because we know that elevation is correlated with suicide rates as well. And essentially, this is what this is the descriptive result that we found, which is that you can see here, and as I've shown you now several times, the suicide rate is increasing and the firearm suicide rate is increasing. But when you look at the time trend in the household firearm rate, there's really no increase across time. The household firearm rate, as determined by this RAND risk score, essentially, or estimated prevalence by state, indicates that there's no increase in firearm ownership. And with no increase in firearm ownership, that firearm ownership really can't explain an increase in the firearm suicide rate. What firearm ownership did explain almost completely was state level variation in the suicide rate. Shown here on the x-axis are the states in the US, and they're arranged by household firearm rate, from the lowest household firearm rate to the highest household firearm rate by state. And then we also graphed on top of that the state's firearm suicide rate. The correlation between state level household firearm rate and the firearm suicide rate by state is 0.81. It's a very, very high correlation. And in fact, when we did these spatial temporal age period cohort models, essentially firearm ownership explains all of the state level variation in the firearm suicide rate. And what that means is that there's no variation state to state left in the firearm suicide rate after you take account of firearm ownership differences by state. This is our attempt to explain the period effect in firearm suicides. So shown here is the period effect from our age period cohort model. We can see that big increasing period effect after about 2009, 2010. And these MORs are median odds ratio. So this is basically the year-to-year variation in the firearm suicide rate, taking out the effect of firearms and putting in the effect of firearms. Essentially, there was almost no change to the median odds ratio. So we basically didn't mediate any of the temporal effect in suicide after adjusting for the firearm suicide rate. However, we did explain basically all of the state level firearm suicide rate as shown here. Oh, no, I'm sorry. This is the cohort effect. We essentially explained none of the cohort effect in firearm suicides either through firearm ownership. So basically what we conclude is that firearms in the home increase the risk of firearm suicide at the state level. This is not something novel. We all know that. And it largely and almost in totality explains state level differences in suicide mortality. But it really didn't explain much at all of the increase in the trend more recently. So recent trends in firearm mortality were due to cohort and period effects. But firearm ownership itself is not co-varying with those cohort and period effects enough to explain the increases. So we've been trying to hypothesize what are other reasons for these increases in suicide, because it's not firearm ownership. Certainly things that we've discussed in our group, and I would be interested in hearing others' opinions as well, are the downstream consequences of the opioid epidemic. We've got, 70,000 plus people dying of overdose by year, and that has a tremendous collateral consequence on families. It's going to increase things like acute suicidal risk. We have the downstream consequences of the Great Recession that occurred between 2008 and 2010. And 2010 is when we started to see increases in suicide in the United States. So certainly the collateral consequences of that recession. We have general declines in social connectedness that have been demonstrated in a lot of different surveys. And we know that social cohesion and social connectedness are a population level driver of suicide rate. But there could be other drivers of the increases as well. And it should obviously go without saying that firearm ownership remains a crucial and necessary mediator in the causal chain that leads to suicide and firearm suicide. It's a really critical, actionable factor. And again, explains almost all of the reasons why different states have different rates of firearm suicide is because of firearm ownership. So it certainly is a really critically important part of suicide surveillance. So I'm going to transition here and just with the time I have available, present one more study, because probably something that a lot of people in the audience are thinking is, you know, you're showing data up through 2018, 2019, but in 2020, we had this kind of major global event that many people predicted was going to have a tremendous impact on suicide, both in the US and nationally. And so I wanted to show you some of the results that we've been putting together on the impacts of COVID-19 on suicide rates. One thing to say quite as a general matter is that now most countries that are reporting data, although not all, have reported that there really haven't been yet a major impact of COVID-19, you know, in terms of illness and as well as the lockdowns and employment distress people have been feeling. There has not been a demonstrable impact on US national rates of suicide, although some states have shown some increases. And then in most other countries as well, there hasn't been a demonstrable impact. But again, some exceptions, you know, Japan being a really notable one. But that being said, we do know that COVID-19 is having a tremendous impact on the mental health of you know, people globally, including in the US. US populations have experienced elevated rates of financial and psychological distress related to the COVID-19 pandemic, either directly through experiencing illness, through losing family and friends, and through losing employment opportunities and other financial sources of distress. And so we know that these things are correlated with things like mental health problems and acute suicidal distress. This figure illustrates that the prevalence of mental health disorders in the US and suicidal ideation increased during the early stages of the pandemic. This is through June 2020. And so rates of depressive disorders, for example, were 4 times that of the same time period in 2019. But these findings are consistent to some degree with also longer term increases in depression and suicide, which we know, as I've said numerous times now, have just been generally increasing in the United States. So the fact that there was an increase from 2019 to 2020 is not entirely surprising given the overall increases we've been seeing for the last 10 years. So disentangling what portion of the increase is due to COVID-19 versus the longer term trends that we've already established is difficult to tease apart. But we're trying to do that in a number of different ways. So I'll show you one example of how we've been doing that. So we've been using data on Google Trends. There are kind of reliable ways to use Google Extended Trends data by searching the density of certain search terms by location, and we can do it by designated market areas for search terms that are correlated with suicide rates at a population level. And so what we did in this paper is try to identify the impact of pandemic-related social restrictions, so the decreased mobility that people were experiencing across the country and across the world. We tried to determine whether we could correlate 2 time series, one being the mobility of people in the United States. When mobility started to decrease, would that increase social isolation, loneliness, and acute suicidal events, and try to correlate that with Google search terms related to suicide. We did this both in New York City, which we know was heavily affected by the pandemic, and especially in that first wave, and as well as we did it nationally as well. We did the same analysis in other cities too. We tried to pick cities that had different epidemics. You know, some cities that had their epidemics really heat up in the summer of 2020, for example, but I'll present to you the results from New York City and nationally. So we really had 2 aims of this research. First, we started with kind of a proof of principle. We know that there were stark increases in unemployment that coincided with COVID-19 related shutdowns across the nation. So we examined the association between trends in mobility, and I'll show you our methods for estimating mobility, with trends in search volumes for economic stressors. And again, this was kind of a proof of principle because we know that there's like a causal relationship between COVID-19 related mobility decreases and increased economic distress and unemployment. So we anticipated that restricted mobility would predict or portend increases in search volumes for economic stressors. We also assessed the impact of mobility on search volumes for mental health and suicide-related searches. And so if, as predicted, search volumes for economic stressors were correlated with mobility, we postulated that search volumes for mental health or suicide-seeking terms would then, if there was a signal there, it would again kind of validate this conceptual model that we were putting together. So our data on mobility, and I should say that we collaborated on this and a lot of our work with Jeff Shaman and his group in environmental health sciences. They've been doing so much of the work on predicting COVID rates and doing prediction models for COVID, both in the United States and in other countries as well. And actually, pre-pandemic, we got funded to do this study to apply his same infectious disease models to suicide. In fact, I think the study was funded in like January 2020, and then Jeff got a little busy very soon after that. But he's been an amazing collaborator through this whole experience. And we've really benefited from Jeff and his team's ability to harness really excellent data sources that they've been harnessing to predict COVID infection and health in the United States. So we use the data that he and his team work with all the time for predicting COVID infection on mobility, which are from SafeGraph. This includes a panel of global positioning system pins from millions of cell phone devices. They're measured daily, and you can get really excellent geographic granularity. So basically, we extracted from that the proportion of time that a cell phone device is at home as our measure, because we're all carrying our phones with us everywhere we go. So if your phone's completely at home, you probably are too, was our rationale. So we looked at the amount of time that your phone was at home, and then the amount of time that your phone didn't leave your home within a 24-hour period. We then extracted data on search volumes from Google Health Trends API. It provides the likelihood for a specific term to be queried at a specific location during a specific period. And so we were able to get that for New York City based on New York City's designated market area. And then we also looked at it for the nation as well. So like I said, our two metrics of mobility were the median minutes of time that devices in the SafeGraph data were at home, and then the proportion of devices that were completely at home in a given day. And then for search volumes, we really relied on existing systematic reviews and meta-analyses of using Google searches to query suicide and suicide-related behavior. So we included the economic stressors. So for example, how much people were Googling the term unemployed or unemployment benefits. Also social stressors, so things like lonely. And then we had mood anxiety disorders, psychosis, a bucket of terms that we called suicide seeking. So how many times Google searches were for things like how to kill myself, suicide prevention, how many people were Googling the suicide lifeline, and suicide neutral. So like, we're not sure what their intent was in Googling like suicides, for example. There are some anomalous changes in the time trend in suicide search terms. For example, when the movie Suicide Squad was in theaters, obviously there was an anomalous increase in searches that were related to suicide, but clearly they were related to the movie. So we were able to factor those out. We followed the method that was described by Tran in 2017 for assessment of suicide search terms in correlation with other time series, and we used transfer function model time series. And what these models do is they employ a process called pre-whitening, for which autoregressive integrated moving average models, or ARIMA models, are first fit to explanatory time series and then applied to a dependent time series. Then we calculate the correlations between the residuals of the pre-whitened explanatory and dependent time series at multiple weekly lags. And what this is, intended to do is to remove spurious correlation, like just because two things are going up doesn't mean that they're necessarily causally related. And so we partition out the variance in those time series to try to guard against spurious correlations of just, two things are going up or they're going down, but we want to get at the causal relationship between them. So this permits the assessment of the impact of our explanatory time series, mobility indicators, on our dependent time series, search volume, such that we're getting at a more causal relationship in theory, if these assumptions are met. So we calculated cross-correlation coefficients and used the existing literature to divide them into kind of small, medium, and large cross-correlation coefficients in terms of the magnitude of effects. In terms of our statistical analyses, we did the analysis from January 5th, 2020, so pre-pandemic or peri-pandemic, through January 23rd, 2021, which was just an arbitrary end date because that's when we stopped doing it. We get new data every day. And so at some point we had to be like, okay, like we're done with the study. And so we estimated weekly lags from -14 to +14. What does that mean? We saw whether mobility indicators from 1 week ago were correlated with search indicators from 1 week later, up through 14 weeks ago, correlated with search volumes 14 weeks later, and the reverse. Our suicide search terms in week 0 correlated with mobility indicators at week 1, 2, 3, 4, et cetera. So here are some of our findings. Basically across locations, this is national and this is the New York City designated market area. Both time at home and proportion of devices completely at home dramatically increased during the early months of the pandemic, as shown in these blue lines on all 4 graphs. So this, for example, is the proportion of devices that were left completely at home. These red indicators over here are for 2021. The blue is for 2020. So if you just kind of follow the national, we had this big increase in people staying at home in the early parts of the pandemic. And then, you know, people started leaving their homes. That went up a little bit during the summer wave of COVID, then went back down and then was increasing again in the fall. And then this picks up then in 2021 because the x-axis here is months. So that's kind of what we expected, but we're able to kind of show that quantitatively. And similarly, search volumes for economic stressors, for example, exhibited the expected pattern. So these are the weekly search volumes for our economic stressors, things like unemployment benefits, eviction, things like that. That went up dramatically in March of 2020, both nationally and fell thereafter. But it's exhibited some peaks and valleys associated with the different peaks and valleys of COVID infection in the United States. And again, this is the little bit of 2021 that we included in our analysis. The fluctuations for search volumes for other mental health and suicide related search term categories, like our suicide seeking categories, were not this extreme at all. There were some fluctuations upward and downward, but much more mild than we saw for economic stressors. But what I'm showing here are heat maps depicting the cross correlation coefficients from the time series. And the analyses have a color gradient with p-values listed in the cells. So the color gradient is associated with the cross correlation function magnitude, and then the p-values are shown in each of the boxes. Red indicates that there's a positive correlation, and blue indicates there's a negative correlation in the time series. And the weekly lags are read from left, so that's -14, and then to the right, which is +14. So interpreting these, like I have to wrap my head around it every single time, but a cross correlation coefficient at a negative weekly lag, say 10, indicates that changes in the explanatory time series, mobility indicators, led to changes in the dependent time series. Here we're showing the results for economic stressors 10 weeks later. A cross correlation coefficient as a positive weekly lag indicates that a change in searches for economic stressors led to a change in mobility 10 weeks later. So it's like a reverse causation type of effect. And then a cross correlation at a 0-week lag suggests that changes in both time series were concurrent. The largest cross correlation coefficients in our analyses, which was 0.6, occurred with the proportion of devices left at home at a 0-week time lag. So that indicates that we observe basically no lag in the association between time the devices were left completely at home and the mobility indicators, demonstrating that as the mobility restrictions increased, search volumes for economic stressors increased both concurrently, but then you can also see that there's red on either side of it, which means that it was also increasing in following weeks. The trends in mental health and suicide related search terms really diverged by location. So shown here is the results for suicide seeking, mood anxiety, and social stressors. This is the top set of bars here are the results nationally, and the bottom set of bars are for the New York designated market area. And this top set are the time at home, and the bottom set are the proportion of devices left completely at home. The national associations were much stronger and more consistent, evidencing a series of medium to large positive cross-correlation coefficients at the 0-week time lag. So that means, again, a positive cross-correlation coefficient means a change in the explanatory time series led to a change in the dependent time series, but they were really occurring concurrently with, again, a kind of autoregressive function as the weeks then lead out from that concurrent time. But we really saw no indicator of that within the New York City designated market area. And so we kind of thought the results were pretty inconsistent. You'd expect that if this was a causal relationship, you'd observe it both nationally and within the New York designated market area. We also did a sensitivity analysis where we included all of the data in 2019. So we thought we could get a more robust and stationary time series, but the results were really similar to the primary analysis, where we saw a really big effect for the economic stressors, which is what we expected and was kind of our proof of principle. But for the mental health related search terms, there was a much more inconsistent effect and limited, much more limited signal. So in terms of our summary of our research, we found that pandemic-related mobility restrictions were contemporaneously linked to trajectories of online searches for economic distress, which is not something that is perpendicular to suicide research, because we do know that economic distress is associated with psychological distress and acute suicidal behavior. But we found that there were positive associations between declining mobility and mental health and related suicide search terms volumes nationally during the pandemic, but at much lower levels in terms of the signal that we were able to detect. So we think that these results underscore the pervasiveness of pandemic-induced economic hardship, and certainly prompt further consideration of the relationships between isolation and these kind of risk factors for mental health and suicide risk in terms of our ability to detect these things directly for self-injurious behavior, intentional self-injurious behavior. Google is a pretty noisy indicator. And so the fact that we didn't observe these signals for the suicide-related search terms could mean that much like we saw for suicide death, there might not be much of a signal yet in terms of how the pandemic is associated with intentional self-injurious behavior, or it could mean that Google data are just too messy in order to pick up that signal. But if there have been other studies that have shown that Google Trends data are pretty useful for detecting these kind of real-time indicators, especially for certain search terms. And so continuing to kind of work on the Google Trends data, we feel is a valuable contribution to the field. But of course, there was a lot of limitations in terms of the mobility metrics and the search volumes that we use. They're really imperfect proxies for like actual population behavior and mental health. And so these are pretty ecological and kind of first pass analyses as we're waiting for more proximal data to be released. We can't stratify the Google Health Trends by key demographics. So we might have picked up more of a signal for young people, for example, but we're not able to know like what the demographics are of people when they Google something. The validity of suicide search volumes is itself variable, and it really depends on the suicide related search term. And of course, the results are not generalizable across the US. So I will stop there and answer any questions that people have about any of this work or the work that we're doing more generally. I'd really like to thank my collaborators on this project, on this grant, especially Jeff Sheeman, who's been a really great co-PI on all of the work. Gonzalo Martinez, who's been a great GRA on the project, and the whole staff and everyone who helps us do this have been phenomenal. So I look forward to answering questions. Thank you very much.
Hi, Carrie, it's Larkin. As always, a really phenomenal presentation. And gosh, it seems like you've been really busy during the pandemic. But I had one thought about the Google Trend data. You were looking on the search terms for suicide and stuff. I mean, I think part of the phenomenon of the internet during the course of the pandemic is that it was actually very connecting for a lot. So maybe if you're looking for other things that they were able to use the internet for during that time, or Google searches, that it might explain why you're seeing that weaker effect for the
And I should note that when you looked at the actual volume of people Googling things, it also like went up a lot during the pandemic. It's like everybody was at home, like, what did you have to do except Google stuff all day? So the actual volume of search terms also like went up dramatically. And so, yeah, we might just be getting a more noisy signal for everything in terms of the Google data.
Or even trying to get information about the pandemic itself might be, another thing to look at in those data.
That's true. That's a good point. Any other questions?
I'm sure everyone is just flummoxed by the amount of detail that you're able to.
Yeah, and like I said, we have, if anyone is really interested in doing these kinds of analyses or getting involved in this kind of work, please let me know. Again, we make all of our code available on GitHub, and every data source that's publicly available is also kind of uploaded to that site so that you can literally go and replicate all of our analyses and play around with it and change things and kind of do your own sensitivity analyses. So if anyone's interested in that, absolutely let me know. We'd be happy to share it.
It might be helpful if you put that link in the chat. If you
Sure.
I have a question. If you have one more minute, do you hear me?
Yes.
Hi, I'm Vladimir Karli. I work at the National Center of Suicide Prevention at Karolinska in Stockholm, Sweden. And we have some debate in Sweden about, as you know, in Sweden, we have very good data in the registries, but we have no real-time data. So, the data comes pretty late, like usually more than 1 year after. We get it with more than 1 year delay. And there is some debate about implementing systems to get real-time data. But we didn't win this argument until now because the big, it's expensive, of course. And the big argument against it's okay, we can identify suicide clusters, but then can we do something about them in terms of implementation and of implementation of specific preventive strategies?
Yeah.
And I wonder what would be your answer to that?
Well, that's actually the reason that Jeff and I started collaborating on this grant is honestly, we were like just talking one day and I was talking about how suicide research is we really struggle with this, like this data delay that we don't know about suicide death at a national level for like a year or two. And he said, yeah, we have that problem in flu too, and I said, well, our data is really, really bad. We don't know, most of suicide attempts don't get captured in any kind of clinical record. And he was like, we have that problem in flu too. Like most flus do not receive clinical attention. I was like, oh yeah, I was thinking that here we are, you know what I mean? And so basically what we put together in terms of this grant and what we're trying to do now is put together a Bayesian inference algorithm, just like Jeff does with flu and Zika and COVID. And we're putting together the Google search term data, data on hospitalizations, data on death, and we're partnering with the Suicide Lifeline, where we have every call to the Suicide Lifeline. We're putting them all together in a model to try to get real-time prediction so that we can harness kind of the crappy information we have at each different level. Like, Google search terms is like noisy, deaths are the tip of the iceberg, hospitalizations don't record everything. But if we put them all together, we're thinking we could get and actually it's turning out that we can predict very, very well what the suicide rate will be for a specific location in a specific year. Now, how that will forecast in the future, we don't know. But our partners on the grant are a lot of stakeholders in state and local health departments who believe that they can use this information to disseminate prevention strategies. We do know how to prevent suicide. And when suicide clusters occur, there are, EIS, for example, has become involved in a lot of different suicide clusters in the United States to prevent kind of a furthering of an outbreak. And so I do think that enhancing Suicide Lifeline resources, enhancing mental health resources in a community that we know is kind of burgeoning on the cusp of an epidemic, I do think that we would have the preventive tools available if we knew where it was going to occur. So I don't know whether we'll be successful, but that's the idea behind the project, is to do that exact kind of real-time forecasting.
Catherine, my name is Maria. I'm with Fogarty, the National Center. I missed the beginning of your presentation. Is NIMH the principal supporter for your work? Or?
Yes.
Okay, just checking. Thanks.
Catherine, Larry here. How are
Hi.
you? Great presentation. So one of my questions is we have a tendency to think of suicide rates being higher in people of low SES and or people who are marginalized ethnically. But
something that we're trying to investigate right now in the death data, we're doing case control studies of the counties that have the highest suicide rates, the highest change in suicide rates across the last 10 years, and trying to understand the economic conditions that have shifted at the county level. We haven't had sufficient data to apply that at the individual level, like how individual change in economic circumstances, it might be acutely associated with suicide risk, but I certainly think in terms of clinical data and what we know clinically, that there would be sufficient evidence to hypothesize that, yeah, exactly, that that there might be it's really the fluctuation in economic circumstance rather than like kind of the baseline potentially.
Well, Dr. Keys, I would like to thank you for your informative talk. And I would like to thank you, ladies and gentlemen, for your attention and your participation this afternoon. And I wish you all a blessed rest of the day. Thank you.